Good day, friends. I am Dr. Sanjay Kavra, and I currently serve as the president of the South Asian Federation of Endocrine Societies. I've been in endocrinology now for 25 years, looking after our citizens, our fellow citizens who live with diabetes. And still, I'm amazed, I'm surprised at the diversity that we see in our clinic. Each and every Indian who lives with diabetes is different, is unique. Let's learn in today's 4D program, in the 35th episode, let's learn how Indian diabetes patients are different. Now, 4D means detailed discussion and dialogues for Indian diabetes. So let's have a discussion, let's have a dialogue, and let's have it in a very detailed manner. But if we need to do this, we need an expert. We need someone who is an expert, who is eminent, who is experienced. So who better than Dr. V. Shashikumar? Warm welcome, Dr. V. Shashikumar. Sir is
Thank
a senior
you.
consultant endocrinologist at Trivandrum at the NIMS Hospital. Warm welcome, sir.
Thank you very much. It's my
Dr.
privilege
Sanjay,
to have you as the host.
we are together, sir, and this Indian proverb, 1 plus 1 is equal to 11. Dr. Sanjikumar brings us in a wealth of experience, eminence, expertise, evidence as well. And today we'll be talking about how Indian diabetes patients are different. And this will help us understand our different challenges. It will help us understand how to read the Western guidelines and how to do the best possible for people who live with diabetes. So, Dr. Shashikumar, warm welcome to the 35th edition, like we said, of 4D. And people from across the country are waiting to listen to you, to gain from your expertise.
Thank you, Dr. Konga. Shall we get to the slides? Today, my dear friends, today we are going to discuss how the Indian diabetes is different from the rest of the world. There are a lot of ideas about how Indian diabetes is different. We have seen it in so many occasions. The response of various medications in Indian diabetic patients are different. The way they approach the problem is different, the complications are different, the dietary pattern is different, so on and so forth. There's a lot of difference between what we see in the rest of the world and in our country. This is important because the nature of the pathological process and the etiology will decide the treatment. Already we have seen that there is a lot of difference in the response to various medications in our population. We are trying to look at these salient differences. Next slide. The physiological differences in the physiological presentation of Indian and Western population is very, very significant. We all know that the onset of type 2 diabetes is much earlier in our population. It is considered that it is 7 to 8 years earlier than the Western population, maybe about 47 or 48 in the Indian population, unlike the 55, 54 in the Western population. Is it the younger age is a constant phenomenon? What we have seen in the last few years, or maybe about 10 or 15 years, you have seen that the patients are coming with type 2 diabetes much earlier, even 30s and 35. Not only type 2 diabetes, the late onset type 1 diabetes, that is also earlier. Early onset type 2 diabetes is earlier. Metabolic syndrome is very frequent. Nowadays, we do find people coming at around 30 or 35 with various problems or the onset of diabetes. So the onset at a younger age is a very big issue, because when you get diabetes at an younger age, you are prone to develop complications much more earlier. Second important aspect is the increased incidence of abdominal obesity in our population related to BMI. BMI has been an old standard in the state population. They have looked at the height and weight and calculated, but it has been shown in our population that BMI is no indicator of insulin resistance or proneness to develop diabetes, because the fat distribution in our people are entirely different. Our subcutaneous compartment is smaller. Our visceral adiposity is more. Our skeletal compartment is smaller. Why this happens? Probably because our insulin resistance occurs much earlier. We all know that our children, the children born in our country, they are underweight compared to the Western children. When there is insufficient nutrient supply to a fetus in utero, naturally the insulin resistance starts there, and it will be associated with various epigenetic changes. And later on, when this child is exposed to plentiness of food, the insulin resistance becomes much more stronger, appears much earlier, and there is increased abdominal obesity. Abdominal obesity occurs because the subcutaneous compartment is not able to accommodate the excess calories consumed by hyperplasia or hypertrophy of the adipocytes, so they are pushed into the visceral compartment. It is not visceral compartment. There is accumulation of fat in our population in the epicardial tissue, pericardial tissue, perivascular tissue, apart from the retroperitoneal, mental, mesenteric, etc., etc. So the presence of ectopic white adipose tissue probably is one of the most important aspects. Greater insulin resistance. This is again, it comes back to the insulin resistance which happens in utero, and then the insulin resistance contributed by the ectopic adipose tissue. Ectopic adipose tissue, it is not a cosmetic problem. Ectopic adipose tissue is a source of large number of adipokines, adiponectin, leptin, momentin, vespin. At least a dozen adipokines are produced from the adipose tissue. Then the cytokines that come from the ectopic adipose tissue, the chemokines which come from the ectopic adipose tissue, and large number of vasoactive chemicals are produced like nitric oxide. So, ectopic adipose tissue or the ectopic white adipose tissue is a source of large number of chemicals which can produce one, huge inflammation, second, insulin resistance. The presence of abdominal obesity, therefore, is very, very critical. Why our patients are different or why our patients have an earlier onset is obvious from the fact that the incidence of abdominal obesity is very high in our country. In one of the studies from Chennai, it has been shown that at least 80% of the females and about 70% of the males do have abdominal obesity. They are not obese by the standards of BMI. But if you take the abdominal obesity or the waist circumference, it has been shown that the incidence is very high, 70 or 80%. By American population, the incidence of obesity by BMI is around 60% or so. But here it is much higher. So we are genuinely obese. And this obesity is associated with increased insulin resistance. As we have mentioned, the inflammatory cytokines, obesity with the increased visceral adiposity is an inflammatory state. Uncontrolled diabetes is an inflammatory state. All this will lead to insulin resistance. Probably insulin resistance, where does it begin? Most probably it begins in the adipose tissue, where the insulin receptor substrate is phosphorylated. The serine moiety, the IRS1, is phosphorylated and the insulin resistance starts. So when there is insulin resistance, the pancreas beta cells will try to overcome the insulin resistance by more production of insulin. Ultimately, it fails and diabetes results. So our people are very, very prone to develop type 2 diabetes. Next slide. The Asian phenotype. Asian phenotype, you see, the various countries have different concepts about BMI, as we have already mentioned. In different populations, it has been shown that the critical BMI, which leads to diabetes, is different. Different populations have different levels of BMI. For example, the Samoans, who have the highest incidence of diabetes, highest incidence of obesity, their critical point where obesity develops and diabetes develops is much higher. It is about 30 BMI. So different population has different levels of BMI, and the criticality of this BMI varies due to genetic reasons or epigenetic reasons. So we are therefore a different group. Increased visceral adiposity, lower metabolic resistance, increased cardiorenal risk. See, we have already seen that the obesity is associated with increased cardiorenal risk. There is large number of inflammatory molecules coming. There is dyslipidemia. All this we need to endothelial changes and ultimately vaso-occlusive diseases, whether it is in the heart, whether it is in the kidneys, whether it is in the cerebrovascular system or peripheral system. So the increased insulin resistance and the consequent inflammatory molecule production leads to various vaso-occlusive diseases. Therefore, even if you take as a nation, we have different types of population with different physical features. You see the subcutaneous fat compartment, if you look at South Indian, it is much smaller compared to the North Indian, for example, a Punjabi population. The difference is huge. Even within the country, it is significant. So you need a personalized approach in each patient to decide what exactly is the pathogenesis and then decide accordingly. Next slide. Lifestyle differences are very, very important. The Western diet, we talk about the Western diet, the Mediterranean diet, these are not probably possible in our country. In our country, the carbohydrate composition is somewhere in the region of 70 to 80%. That will vary from population to population, religious groups. There are so many factors that will decide the composition of the diet. Our religious practices, our dietary practices, social factors, financial factors. It's not easy to put a patient on a high protein diet when the patient is very poor. So the diet pattern is different. And then we imitate a lot of Western diet culture. Our system or probably our genetic makeup is not suitable to a Western type of food, probably. So, yeah, apart from all the social and financial factors, there are certain genetic factors. The changes in the farming and actual practices, increased availability of processed foods, that's also coming from mostly in the cities, increased consumption of sweets, social stress, perception of diabetes, that itself is different. People are not aware that diabetes is a condition which can lead to significant cardiorenal disorders, and it will lead to a lot of morbidity and mortality in our country. So the whole scenario is different. What we find in the Western population and in our population, they are drastically different. Next slide. The challenges posed by the type 2 diabetes in India. There is a rising prevalence of urban and rural areas. Previously, it was thought that in rural areas, the incidence of type 2 diabetes was very little. Now, people will find that the incidence is increasing in urban areas as well as rural areas. The economic changes probably is one thing that will contribute to that. When your financial status improves, that is first reflected in your dining table, the type of food, it becomes more refined, it becomes more having saturated fats, etc. Rising prevalence among young people, that is another factor. Limited healthcare facilities. You see, we do not have an universal health insurance that will cover all the poor people. It is partially by the private sector and partially by the government sector. So the cost of the treatment is also very, very important. High prevalence of pre-diabetes. Pre-diabetes very often is not detected. Even the surveys show that some of the studies which has been conducted in Indian Institute of Diabetes has shown that almost 20% of the adult population do have either IGT or type 2 diabetes. And the delay in the diagnosis, probably because of our health system, very often the lower strata of the society do not get the appropriate medical attention, and the diagnosis of type 2 diabetes is delayed. High cost of diseases, again, poor insurance coverage of the population does not offer adequate medical care to all the category of people. Rising rate of diabetes complications. The complications means, again, the cost of the medical care goes up. For example, if the patient has a renal problem, the treatment of chronic renal disease leading to dialysis, leading to renal transplantation, these are extremely complex in our society, and it would be very, very difficult for the lower strata of the society to avail these facilities. Genetic and environmental risk factors, genetic and epigenetic changes. Probably epigenetic changes are more important because epigenetic changes are created by some sort of nutrition which you receive at an earlier age, which can decide the epigenetic changes. Regarding the genetic changes in type 2 diabetes, we are not very aware of that. Low disease awareness among the public. See, again, our people are engaged with so many other things. This diabetes is not a big issue. This is one of the issues he faces. So it may not get the appropriate attention um, from the system. Suboptimal diabetes control. Again, that indicates or that shows a finger towards the medical care? Are we exerting enough to identify the diabetes or controlling the diabetes appropriately? ICMR data shows that the average HbA1c achieved in our population is somewhere in the region of 20%. If you want to achieve somewhere less than 7%, mostly it is around 9% is the HbA1c. So the treatment is very, very complex in the current scenario. Next slide. Management of diabetes. We need a proactive approach. As I have already mentioned, you need to know about the type of the diabetes, the social, economic, and the pathological features of diabetes before deciding on what should be the treatment. Frequently, there's a delay in advancing monotherapy to combination therapy. In this context, it will be interesting to know that in Japan population, East Asian population, they may not start the patient with metformin. They rather go for a D4 inhibitor to start the treatment because they think that the insulin deficiency is more predominant in them than the insulin resistance. So, in our population also, we have to look at the different criteria, different pathophysiological features, and decide what should be the first treatment or whether it is right to go with a combination of therapy in our patient. Therapy should be individualized, taking into consideration whether the combination therapy is beneficial, or we need not be very rigid about it. Try to control the diabetes as early as possible and as meticulously as possible. This is the only way, as we have seen the legacy effect and all, you try to control the diabetes early, meticulously, you can prevent a lot of microvascular and probably macrovascular complications. Yeah, there is no harm in using even multiple drugs in achieving an adequate control. Adequate control very often, it should be around 7 or 7.5 is the usual levels recommended in a patient with any major significant comorbidities. In this context, we should remember that some of the new drugs which have come to the market, two SGLT inhibitors and D4 inhibitors. These are different from the conventional sulfonylureas. The first thing is D4 inhibitors have a glucose-dependent insulin secretory system. So the hypoglycemias do not occur, and the insulin is secreted through the sodium-potassium ATP cell in a glucose-dependent fashion. As I have already mentioned, about 70% or 80% of our population have abdominal visceral adiposity or obesity. So, in this context, probably SGLT inhibitors are very, very important. Not only that it reduces the adipose tissue, it can push out the glucose load in the system in a non-insulin dependent fashion. And the various studies have shown the cardiovascular benefits, renal benefits. Of late, there are some studies which have shown that even in diabetic retinopathy, the SGLT2 inhibitors are beneficial. So you have to take into consideration all these factors before deciding on the type of therapy. SGLT2 inhibitors in combination with D4 along with metformin seems to be a fabulous combination to achieve a euglycemic state. SGLT2 inhibitor with the D4 inhibitors are available now along with metformin. It seems they are safe. They achieve the glycemic control very, very, very quickly, improves both insulin resistance and beta cell function, reduces the body weight. Probably that's the most important thing. We use insulin, we use sulfonylureas, and then we cause a weight gain. In spite of controlling the blood sugar, the patient will gain about 3 to 5 kg. If you are putting the patient on long-term premixed insulins and sulfonylureas, when we achieve euglycemia with the consequence of adding weight, then probably if you are looking at the pathophysiology of obesity or the pathophysiology of the visceral adipose tissue, your treatment to prevent the vascular complications does fail at that point. So when we treat a diabetic patient, it should not be at the cost of weight gain. If you can use a combination SGLT2 inhibitor with D4, the pill burden may be reduced, and overall cost-effective. Cost is definitely a consideration for us because we have seen that with the reduction in the price of D4 inhibitors and SGLT2 inhibitors, the drug has become available to a large number of patients. I think I will write up my slides here. Dr. Kalra, it is up to you.
Yeah, thank you, sir. A great discussion, a complete discussion actually about all the various aspects of Indian diabetes. And that is what our viewers want to learn actually. So, a few questions coming up. One question is, you work in a part of the country where there are different ethnic groups, and also there are some people, some patients who are living in India, others who come to you from the Gulf, for example. So, what is the difference in healthcare seeking behavior? Their
What is
attitude
the
towards healthcare seeking behavior, their attitudes towards healthcare. Does that make a difference to treatment?
it makes a difference because you can see that the girl patients coming from girls, they are more careful about the complications of diabetes. They are more strict in achieving a glycemic control. But the problem for them, that's an entirely different problem. When they come to India, it's easy for them. The medications are available cheaper. If they are going back to the Gulf countries, the medications are expensive. The follow up treatment is also not very meticulously done. When they come here, they do all sorts of things and get a proper treatment.
Right. So that also we should figure in when you have patients coming from a rural background, an urban background, from educated background, uneducated background. Each patient will be different. So I think the treating physician should keep that in mind as well.
True, true, absolutely true. Not only rural and urban areas, you have seen patients who from coming from your area, Punjab and Haryana, you can see that the subcutaneous fat is much higher compared to a South Indian population, somebody coming from Kerala or Tamil Nadu. This makes a huge difference. People who cannot expand their subcutaneous adipose tissue, they have a tendency to push the fat to the visceral adipose tissue, and they are more prone to develop more complications. I have seen plenty of patients from Punjab, absolutely metabolically healthy, obesity. We call them, probably it is very common with those populations. In spite of their large fat intake, their carbohydrate consumption is relatively less, saturated fat consumption is more, but still they are quite healthy. What do you think about this metabolically healthy obesity? What do you think?
I think
Is
it
there an
exists, sir.
entity like that?
There is a lot of debate, a lot of controversy, but I think it exists. So obesity is just
Is it
one
only a
aspect of
temporary
overall
phase?
health.
Is it
I
only
think
a
it exists.
temporary phase, or ultimately they become unhealthy obesity?
You can continue in metabolic health for a long, long period of time. But the trick is that you have to keep on exercising. So even if you try to lose
True.
weight, even if you don't lose weight, even that will help. So the fact that you go to the gym, you exercise regularly, take care of your diet, even if your weight is not coming down, at least the weight is not going up, and at least other metabolic ill health is not coming. So you need to work on it continuously. Sir, you spoke of carbohydrates. So this question coming from one of our listeners, that is, in some in some platforms, they tend to criticize Indian food. Is it necessary for an Indian living with diabetes to take Mediterranean diet, or can we manage good control with an Indian cuisine?
See, from what we have seen, it is not easy to enforce Mediterranean diet in our population. There are social factors, economic factors, religious factors, etc., etc. You have a huge number of vegetarians in our country. Huge for vegetarians. What is the source of protein? How are you going to make sure that the patient takes 1.5 grams of protein every day per per kg? It will be very, very difficult for a vegetarian to devise a diet with 50% carbohydrate and sufficient protein. That's definitely a tough task. But in spite of that, I still believe that there are epigenetic changes and genetic changes in our population. We are used to taking a large carbohydrate diet. Probably the advantages of Mediterranean diet. Mediterranean diet is not an artificial diet. Those people are used to taking that particular diet in all the populations. It's a very, very, very long time. So they have a system to deal with that. Here we have a system where we take 70%, 80% carbohydrate, and we are comfortable with that. Not only carbohydrate consumption, how a particular individual's body react to that carbohydrate consumption. There are vegetarians who take almost 80% carbohydrate and they are absolutely fine. They are healthy, no problem with that. But there are people who take a lesser percentage of carbohydrate with a lot of complications. So, not only the composition, probably our genetic makeup is also critical in deciding what happens with the carbohydrate we consume.
And one other question again. In South India, coconut oil has been used for centuries, for so many generations. And when you read
Yes,
some of the literature from the West, they use the word tropical oils or palm oil
tropical
and
oil.
coconut oil as if being from a tropical country and having tropical trees is a crime. So, your take on this? Coconut oil and
See,
health.
we have to look at what happened in the industrial field in the last 20 years or so. Initially, coconut was plucked, it was dried in the sun, and then extracted manually or using some very small mills. It changed. When it began the whole process, the whole industry became industrialized. This is tried using very high temperature, and some benzene is added to the coconut. And extraction, they use certain chemicals, decolorizing. There's a process called RBD, refining, bleaching, and decolorizing. All the coconut oil, which is readily available in package form, is going through a process called RBD. It has been shown very conclusively that the conventional coconut oil is different from the what's available in the market as RBD coconut oil. The smoking point of RBD coconut oil is quite high, unlike the conventional coconut oil. Conventional is so. My point is the way the coconut oil produced in our country has changed, and therefore all these hazards have been attributed to the RBD coconut oil, not the conventionally extracted coconut oil.
That's a very important point, I think, which Dr. Kumar is sharing with us. And this is how you see that eminence and expertise combine with evidence to give us the right answer for our patient. And that is actually the aim of 4D, so that we are able to initiate dialogue, initiate discussion in a very detailed manner, and we are able to learn from the experts. I'd like to thank everyone for having logged in today to this episode of 4D. And sir, thank you so much for your comments. What you have taught us is not written in the textbooks, but this wisdom is
Right.
important for all of us. And speaking of coconut oil, what I will tell you the Haryana Punjab perspective. We think that all the people in Kerala, they have very high IQ, and the reason is that they take coconut oil, and that improves the hair health and also the IQ. So that is our impression of coconut oil, and we are very happy with it. So
Thank you, Dr. Kalra. Good night. I think that is the end of the session. Is it?
goodbye and thank you, and thanks everyone for listening today. And we hope to welcome you again to be with you again in the next episode of 4D next week. Thank you and Jai Hind.
Thank